Hi, everybody. My name is Natalie Luna Rose, and I'm the Communications and Outreach Manager for the Arizona Center for Disability Law. I would like to thank all of you for coming today. This is this is our 12th session, and we've missed a week or two there. So technically, we're in like 14 weeks now. I counted this morning, and so this is these sessions have proved to have been useful and fruitful, and I think really good information have been passed between not just the agencies, the Arizona Development Disabilities Network, but also our partners with this, and just you who come and attend these Zoom sessions, calls, or whatever you want to call it, but where our lives are today. So today's session is very timely, and I think very much needed. In our discussions, I think we've had a lot of them within, as a group, within our own respective agencies or at home or in schools, and that is the issue of racial disparity among people with disabilities. We felt that it eventually, this was a conversation we were going to have. We try to be culturally and linguistically relevant in a lot of our agencies, and then just what's going on nationally just seemed to highlight that this is a much needed first of probably many conversations on this issue. So we have two speakers today who I'm very excited that'll be joining us. Dr. Angela Allen, who is with Banner Medical and also the ASU College of Nursing, and Dr. Adele Allison, who is with the ASU Disability Resource Center, and among other things, both very accomplished women in their own respective fields. So I honestly don't remember who was going first, so sorry about that, but I guess we could go with Dr. Allison, if you'd like to jump in first, since I see you first, right here.
Okay. Yes, I was looking at the schedule and that's what it says, so I will begin. And really, I just wanted to kind of give an overview of where we are. Currently, we're living in a time in which the limitations of our society are being exposed. Inequity in income, healthcare, living situations, and civil rights have come to the forefront of our news. Economics, those with low wages, little to no savings, have higher exposure to risk and higher rates of termination from jobs. The pandemic has created a situation in which social distancing has led to changes of routine. No more hugs or high fives, mask blocking facial expressions. You look at someone and go, was that a frown or a smile? Housing inequities place more people in tighter living situations, increasing the risk for all. Isolation has disrupted daily routines. Societal violence is on every front. Tensions are rising, both with tight quarters and the heat. Street protests, shrunken safety nets, unreported abuse, and domestic violence. And all of these impact the least noticed among us are experiencing the greatest fallout. I believe we're all in uncharted waters. The upheaval of routine and structure impacts probably more than anyone else those who have difficulty adapting. If their adaptive functioning is just not quite on top of it, it's difficult to deal with the changes. And the systems that we're used to have all been disrupted. Transportation continues, but if you use public transportation, then you expose yourself to people in situations where previously there were crowds. Support systems, whether they're professional support systems or natural support systems, vary, especially in the case of natural supports. If people are living independently with professional supports and the professional supports have gone to working from home, then the natural supports aren't necessarily in place. People who've been in school where it's been highly interactive in-person classes find themselves in remote settings, learning new technologies and trying to figure out how do I interact with my instructor, my co-classmates, and the material. With employment, there's been more change. High-risk jobs, the risk has been increased in some jobs where it was just a matter of customer service, and now it's a matter of customer service with masks and gloves. Loss of jobs for people who can barely afford to exist week to week. Communication has shifted from in-person to phone, to Zoom, to text, creating not only a difficulty in reaching each other, but the loss of social cues. I spoke with someone from our church this week just to check in and see how she was doing, and found out that because she doesn't really use Facebook or her email, which she does have an email account, she didn't know we were having church services every week. So she's lost connection with the spiritual community as well. Healthcare, coexisting conditions create more risk. Elective treatments were delayed, limited access to medical professionals, and telemedicine that works if you can describe what your symptoms are clearly enough for a doctor to work with you. I think the effects of all of this have been stress, whether we can adapt or not to the stress, whether it's good stress for us or bad stress. You know, some people are happy to be working from home. You see, my favorite background is with my dogs. Personally, I'm glad to be in my office where my dogs lay at my feet. But some people are stressed by being away from the work environment, or away from their school environment, or away from their daily activities. And that stress is so real. It can be physiological, the starvation for touch. You know, we really do need hugs, handshakes, the embrace. Psychological, there's an abrupt change to everything that we know. And how are we dealing with that change to what should be coming in and going out? What should mean this now means that. Emotionally, our familiar friends and routines are no longer available to us. So we're not able to spend the time that we used to with the people that we really like to spend time with all of the time. Spiritually, the ability to go to worship has been interrupted, regardless of what worship a person goes to, whether it's Christian, Muslim, Jewish, Buddhist. It doesn't really matter where you get your spiritual fulfillment. If you get it in a group of people who congregate together and you've not been able to congregate, then you've lost that connection as well. These factors impact persons with disabilities, low economic status, LGBTQ community, and minorities, African Americans, Latinos, Native Americans. We need to consciously identify ways to remove structural inequality and to establish a balanced structure that is not only a response to this pandemic, but also creates balance for our future society. And I'm going to pass it on to Dr. Allen.
Thank you, Dr. Allison. And I could not emphasize what you shared most. I think most of the information that you shared would have been what I said. One of the things that we have to recognize is not only are we impacted by just social justice or injustice, if you will, but we also are affected by something that we consider very deadly, and it is deadly. We are looking at something that's called coronavirus or COVID-19. Many of us are familiar with this term and have been familiar with it for such a long time. As of January, we were introduced to it. March, it impacted us, not only in our state, but in our country. In addition to that, it also affected us just recently when our numbers just doubled within the past 3 weeks. Also, we have to realize that it did not affect us as a physical aspect, as Dr. Allison so graciously stated. It also affected us in a social aspect, and also in many cultures, a spiritual aspect. But on top of that, we have to recognize, again, this social unrest or injustice that we've identified just as recent. This injustice has caused us not only to rise in our numbers, but also to affect us in a way in which our country did not expect. But let's add on top of that, those who have disabilities. In my area, as I've been introduced, I work at Banner Alzheimer's Institute and Banner Research, as well as the Arizona State University. And in this capacity, I have to recognize not only the health issues or the injustice issues, but also those who have some form of disability. In my area of the disability has been more focused on the neurological aspect as it relates to dementia. Just imagine the numbers of patients that I see on a regular basis based on not only just their illness, but also based on all the things that are going on now. We know that in many of the nursing homes and also facilities that this particular population makes up about 9%, but yet they are affected by this disease by 33%. So it's important that not we only recognize what's going on around us as it relates to culture and health, but also what's going on around us as it relates to the disabilities that many of these people impact. So thank you, and I look forward to hearing from your questions. And again, thank you, Dr. Allison. You shared a lot of information that I think many people will actually grasp that I would have shared. So thank you.
Okay. We're gonna open up for questions. I do want to mention a little bit of statistics that came out. There was Arizona Republic article, I do believe yesterday, the day before yesterday, and Sarah, you may want to remind me on that, that spoke of this very issue. And there were statistics that came out that concerning COVID that the Latino community, well, this was from our partners over at Chicanos por la Causa. So as of June 22nd, COVID-19, and we'll break down by ethnicity the numbers, COVID numbers. So for Hispanic Latino was 26%, white non-Hispanic 17%, Native American 10%, Black 3%, other non-Hispanic 2%, Asian Pacific Islander 1%, and then unknown at 42, people who did not self-identify. So it turns out that the largest demographic groups affected are Hispanic Latino, and women also have a higher rate of infection, but the age group that is affected the most are men at age 20 to 44. So it's not obviously just a virus that's affecting those who are 65 and older. This seems to be like a non-discriminating virus. So I just wanted to give out those statistics. So I hope this would be a very interesting and lively discussion. So if anybody's would like to start off asking either Dr. Allison or Dr. Allen some questions, we're happy to open the floor.
Just as a reminder to everyone, you're welcome to share in the chat. If you share in the chat, I'll make sure that the question gets read out loud. If you want to share verbally, we're encouraging people to use the raise hand function. So you can do that by clicking the participants button at the bottom of your screen, and then the raise hand button at the bottom of the participant screen. If you're on the phone, you can dial *9 and you'll shoot up right to the top of our list, and we'll make sure you'll get unmuted if that's the case. I am seeing a hand raised from the phone, so I'm gonna unmute you in a minute. The phone number ending 3477.
Good afternoon. Thank you so much, Rami. The question that I have is for both presenters. The populations that I work with specifically from a paid standpoint, as well as volunteer, are under the LGBT spectrum, of color, housing challenged, substance using, mental health, as well as physical disabilities. Yes, many of the issues that are going on currently have shown inequities and disparities. Are there things that you all see that are coming in the pipeline horizon that may be a temporary stopgap, Band-Aid stitching, as well as long-term ideas for potential diminishing that inequity disparity, so that, because we've been listening to the numbers, it was just interesting, hearing it, even, on the daily basis of how it's all spread out, and especially with our male folks are between the 20 to 44, I believe, if that you stated.
So if I'm clear, this is Dr. Allen. If I'm clear, I'm trying to get that question. If you can just ask the question, the specific question, I just want to make sure I'm asking it correctly.
Specifically with our communities who are under the LGBT spectrum, with disabilities of color, and our women, and knowing what the disparities are right now, and seeing them more in front of your face. Are there things that are on the horizon, or that you could suggest to help diminish those disparities, so that when the next thing comes, or even while dealing with this, that everyone has at least access and equity?
Absolutely. So that's a very good question. You've actually identified 4 variables, and that's actually interesting because it's a tough one. When you add in traditional variables, you actually have to focus primarily on one in particular. One I will particularly focus on is people of color and LGBTQ. One of the things that we recognize is that even in this recent situation and this social injustice, if you will, including the COVID, but just particularly the social injustice, eyes were awakened, if you will. People were aware, are now aware of the major concerns that we are encountering. One of the things that have been recognized in large corporations, and I'll give you 3 in particular, and Dr. Allison jump in at any point. One is the fact that they could not, and I like the fact that you said that they can no longer put a Band-Aid on anything. They now have to begin to build programs that are sustainable so that they can recognize that there are some concerns, and those concerns aren't going to go away. The second thing, Arizona Community Foundation has began to look at funding for most of the variables that you've identified, where they can actually not only reach the needs of those of disabled, but also reach the needs of those of color, reach the needs of those that are maybe in a gender preference, and to recognize that funding is needed for several of these organizations that are trying to do the work in the community, and particularly to make people identify that there's a concern, to make people aware of those concerns, to implement programs that are going to be sustainable, and to empower not only individuals that are involved, but also those who are encountering those situations. And then the most important thing is that looking at large corporations that have focused primarily on what their purpose is, and not the fact that they're servicing certain various people. Corporations such as Banner Health, Arizona State University, and the other. And I only speak for those 2 because I'm involved in diversity and inclusion projects that are going on now, in which we are trying to address the need, instead of being reactive to situations now, but being more proactive. We're also looking at minority organizations such as the Hispanic Nurses Association, as I think pointed out earlier. We also are looking at the Black Nurses Association, so that we can begin to collaborate with diverse organizations to, again, meet the needs of those in the community from a health perspective, or from a perspective of, again, someone who looks like them or are very similar to them.
I would say also that working with groups within the community to really push that out at a grassroots level. I know our church has partnered with the Black Nurses Association for our health fairs to make sure that the LGBT community has access to the kind of information that a lot of people just don't get if they're low income with a disability and don't have transportation. They can walk to our church, they come in and get their blood pressure taken and various other tests. So we really need to create more partnerships from top to bottom and bottom to top, and we need to do more to provide the kind of health coverage this nation should have. We should be covering everyone, not just the top, because as you can see, if anyone doesn't have the coverage, then it spreads rapidly to everyone.
Okay, Again, keep your questions coming, but I wanted to also speak on some our partners over at Raising Special Kids. They obviously, judging by the name, work with a lot of families, and they work with a lot of bilingual families. And what they've heard during this whole COVID event is that many of the Spanish-speaking families, that they've struggled to find providers, and they've struggled to find Spanish-speaking providers before COVID, and after COVID, it has just become near impossible. So and because of COVID, there are families who are afraid to take their children to therapies or having therapists come to their home. And so bilingual communities are definitely feeling, I think, the struggle even more so, because COVID has just made it impossible. So are there, any thoughts and suggestions or more questions that we can take back to our respective communities?
Yes, this is Dr. Allen. So one of the things that even Banner has done, I know Mayo has just done it, and I think Honor Health is also beginning to implement certain things. And I'm only focusing on the healthcare industries and the primary care settings. Many of us know that COVID is about 6 months old in Arizona, or in the United States, if you will. And one of the things, even Dr. Fossey mentioned it today, we are learning this disease as we go. And one thing that we have recognized is that we've left out a lot of the cultural diverse aspects, particularly the literature. If you know, the CDC started with English, and then they began to start adding more and more information as it relates to COVID on their CDC website, to provide information where people can actually understand what they're reading and also understanding literature. As far as in the primary care settings, you are correct for the person who asked the question. We are having difficulty, even in the Banner, particularly in the Alzheimer's Institute, we're having difficulty where we have patients that are being seen by e-vision or telemedicine. And what we've been doing now is actually redirecting those individuals to our Spanish-speaking or other speaking persons in our area. One of the things that we do in the inpatient setting and also in outpatient is we try not to utilize our healthcare specialists or the family members when it comes to communicating information to individuals during primary care visits, et cetera. Now, unfortunately, we had to turn the table. I think Dr. Allison said it very well. We are now changing the way we do things. And so now we are asking more of our family members to basically be included in interpreting. So in our recent visit that I had just not too long ago, one of my doctors, I was sitting in the room with him, and he said, I have a Spanish speaking person, and that's going to be one of my dementia patients that's going to be on the call. I now have to ask her granddaughter to interpret the information for me in order for me to understand. So now what we're doing is we are including family members to interpret information to their loved ones so that they can have a better understanding. Unfortunately, we have not provided the resources, again, because this is so new, and we have not actually utilized the technology that we have used in the clinic or in the hospital setting. So I hope that makes sense. We're now using more of the family members, and we're encouraging you that if you do have someone that's Spanish speaking, whether they have some type of physical or cognitive disability, to let them know that you do have a family member or maybe a friend who can be bilingual and interpret that information.
Thank you. I see a hand raised from our participants. So Celeste, in a minute. Oh, yeah, it's still raised. I'm going to unmute you now, Celeste, and you'll be able to ask your question.
Hi, my name is Celeste Nuñez. I'm here as a student researcher from U of A. I'm involved in looking into how specifically Native Americans with IDD are affected by everything that's going on. But I do have something to piggyback on what I think Dr. Allen said about the Spanish speaking patients and how it's been an issue about communicating with them and having to have the family members interpret. I know insurance have, and this is from past healthcare experience, I know insurance have had issues well, providers have had issues with insurance trying to have them pay for telehealth visits. But I do know that in-person visits, insurance were required to pay for an interpreter to attend, right? A lot of Hispanics like myself didn't know about this, but hospital administration people know that insurance are required to pay for the interpreter if they ask for it. I even used to work as a Spanish English interpreter. So I know I worked for, I can't remember the name of the company at the top of my head, but I wonder if we can talk to those companies and somehow, well, not we, but like, I wonder if that's an option to get them involved in the patient's appointment. I can't remember. It was over the phone interpretation. So the patient will go to the Spanish speaking patient or any Kurdish, any other language, right? That wasn't fluent in English. The doctor would call this number for an interpreter, and the interpreter the doctor would have a phone, the patient will have a phone, and there was a third party person interpreting back and forth. So I wonder if that can be done through Zoom, if that can be incorporated. I don't know how that would be with the payment of insurance companies, Medicaid, Medicare, but I know like even telehealth, it's on itself, it's a big movement and there's a lot of moving pieces. So this might be another, maybe too much, but I think that's a good idea to keep in mind, just for the communication, language barriers, how it can help out the communication of health and all that down the road.
So I can't speak, that's a good question. I can't speak for all insurances, but I know CMS is looking into that. You have to, and again, I started the conversation off by saying that the disease has affected the way we are now caring for our patients. And so unfortunately, because it's only 6 months, every moving part is being prioritized. So that's a good question. We are looking at ways in which insurance can pay. I think someone actually also put in the chat that we are also looking at contracting with organizations, but large organizations such as Banner and other hospital settings, they actually are unable to contract with small businesses. So right now, I am speaking primarily for research and Alzheimer's. We are looking for large organizations that we can contract so that we can get an interpreter involved in this process. We have had smaller organizations because we did, if you guys remember that we've used telemedicine in the past at a small, obviously small, a portion. We've also utilized eVision, and then also Philips. Philips had a program where we were utilizing communicating technologically. But right now, because this is such a big surprise and we've actually been affected by something that we didn't expect, and we believe it's going to be long-term. So that's an excellent question. We are looking at organizations that we can contract with so that we can have interpreters. As far as in the inpatient setting, we've always had interpreters. We've utilized a program or software on our WOWs, we call them WOWs. We've utilized that where we actually call in, we have trained staff who actually are called in and they're able to interpret information in the inpatient setting. But in primary care, we're looking at contract.
I think also the relaxing of rules around telemedicine has increased access to telemedicine for a lot of people. So it does indicate that we need to check and make sure that along with that, they've increased access to interpreting services. And as mentioned in the chat, to interpreting for sign language as well.
Yeah, thank you. I just want to catch up on some things that are going on in the chat, just especially if you're on the phone or you're not able to view the chat for some reason. So a link was shared to Arizona Community Foundation grant opportunity. There was a link to some CDC resources in multiple languages. I think it was the Spanish link that got shared, but the comment was that the CDC, as Dr. Allen mentioned, the CDC does have info in multiple languages now. A link was shared to Chicanos for la Causa's research page in English and Spanish. Jamie shares that the Division of Developmental Disabilities, DDD, held a Spanish-speaking virtual town hall and are working on setting up another. Jamie encourages individuals to let DDD know that they want another town hall in Spanish. And there's a phone number there and a link to where you can find out more information. and also a link for Black Arizona COVID-19 Task Force website. Christina shares, DDD uses Kathy Hansen Interpreting Services. Fiona shares, I know for sign language interpreting, video relay is not supposed to be used for interpreting where both parties are in the same room, but maybe that has been relaxed under COVID. There's a link to an organization called Curacom. Sarah shares a link to Indian Country Today has some maps and charts. Kristen responds to Fiona, yes, that has been a policy for medical or legal. Yes, that has not been a policy for medical or legal situations. It's absolutely relaxed at this time for other meetings per community outreach program for the deaf. Just a reminder, if you want to share verbally, to use the raised hand function by clicking participants and then raise hand. Or if you're on the phone, dialing *9.
And I'd like to mention that Vicki has mentioned that Raising Special Kids has a Facebook Live in Spanish for families on Wednesday. So thank you for everybody for the information. It is very helpful. We put it on, if this is your first time in the call and you got our invite through one of our, from one of us, we have links to previous sessions, but also a link to our ever-evolving FAQ page, and so we'll have all these links there. It's updated fairly regularly. So any more questions? I don't be shy. We've got a lot of participants today, so really encourage you, even if you don't want to raise your hand, you're more than welcome to put it in the chat if you're a little bit more comfortable.
Okay, I see that Erica has a comment. Erica, you're unmuted now.
Yeah, hi. Hi everyone. So I'm just gonna bring up something that's come up, and it's maybe addressing an elephant in a room here. And I don't know if our panelists really have the answers or if it's more of a group discussion. But you know, we've been talking for months now how a lot of our people that have developmental disabilities are living in group homes or adult developmental homes. And so some of them have behavioral issues and are kind of stuck, can't get out. And we've talked to some provider agencies who've said that that over time, it's actually, some of them it's actually gotten worse and they're not quite sure what to do. Now, among the group home residents, some of them are people of color. And a few years ago, I was a researcher on part of a study with the Phoenix Police Department. And in that study, we did half of the people, we talked to over 200 people with disabilities. A majority of them are people of color. And we talked to the police department. And about half of the people with disabilities that we talked to said that when they interacted with police, that their situations were worse, became worse, not better. These people were in crisis. And when we talked to the police, they said often that they would get the same calls, and it's usually people eloping either from group homes, people that were having to be taken to hospitals. So they're doing a lot of mental health calls. I have the report I can share with you all, but I guess my concern is moving forward is with COVID and people might have, you know, needing to get out or run off, like just to make sure that we are aware that our behavioral supports are so important right now for the long run. And how can we be sure, working with the police department as well as with our behavioral health agencies, that our people that happen to have developmental disabilities or people of color are safe throughout this pandemic and they're adequately supported. And it's a huge problem. I don't expect that anybody's going to have the answers today, but it's something that I'm hoping as a community that we can make sure that that they're safe.
So Erica,
and I'm going to touch the link.
You raise a very good point. So let me just share, and again, as a researcher, I focus on variables. You just added 3 variables to your question. The first one was people of color, not just of African American, but of any color. You also raised the person with disability. And in my aspect, I'm going to focus more on the cognitive when I begin to talk and respond to that. And then the third thing you added was policing. So you have three variables that are listed there. And one of the things that we must recognize prior to any of the things that you've just shared is that we have to be proactive, not reactive. We are all reacting to three that Erica pointed out. We are reacting to a disease that we have very little knowledge about. Once again, it's 6 months old. It's attacking our respiratory system. About 80% of our people are actually, they obviously come out of it. 20% of them die. Most of them are in the facilities because of the fact that they are actually congregated into smaller areas. And then we also have the cultural aspect. Speaking of cultural, as I mentioned earlier, I teach culture and health at Arizona State University. So you're now looking at a particular group of people, particularly those who are healthcare providers, who are unable to interact with a particular culture because of minimal knowledge. Most of the training that are done inside of the healthcare facilities are probably once a year, maybe twice a year, 1 hour long, and they're probably focused on maybe something that has affected them that day or during that week. And then lastly, you're talking about those who have some disability. In my world, disability is primarily the cognitive aspect. So if we address those, we must address them in not just together. It becomes overwhelming, not only for the providers and those who staff who are working in the communities or in those settings, but also to the patient. What we must do, first of all, is recognize that there is an issue with cultural competence, that we must begin to educate our staff, our providers, and our community in which these patients sit or stay or congregate, because this is their resident for a short period of time or long period, depending on their status. We must be able to, first of all, identify the issue, make the staff in the community in that setting aware of the concerns that are going on, have them apply their skills because they have been trained to do something. Obviously, whether it's a CNA, a nurse, or whomever, they've been obviously trained to do something, apply their skills, then apply what they've encountered, whether it's a presentation, whether it's TED Talk, whether it's a group setting in which they all sit together and say, this is what I've encountered. Now, I'm only focusing on culture. This is what I encountered on this particular group of people based on the experience that I've seen or heard. And then we have to be able to empower them, because we have to, again, once this process is done, we have to be able to make sure that they understand who they're working with, despite their cognitive impairment or anything like that. But we're focusing primarily on the culture. That's only the healthcare providers or those that are in that setting. And then we also have to look at the disease. When we recognize that this disease Dr. Fossey has said this thing over and over again, there are several guidelines we ask you to follow. Social distancing, we know the rules, very little contact, wear your mask, et cetera, et cetera. We know hand washing. When you are able to become first culturally competent, and again, I wish we could make this before the disease come out, but being culturally competent and understanding that particular culture you're working with, and then educating them or helping them understand, how do I apply these rules to this particular culture? Then you will decrease the policing or decrease those who are coming into your environment. When I say the worker's environment, the patient, because what they're seeing, and I'm focusing primarily on the cognitive aspect, they're seeing what we call as a double impact. They're seeing the fact that I've seen this on television, or I've seen this that's going on around the world. So to see this person come into my area or our area in which we are actually working in, or you're helping me or servicing me, because you don't understand me as a culture, because you don't understand my disease, which that's another story, because you've not been trained enough to understand whatever the cognitive impairment issue is, then you begin to bring someone in my world. So what's happening is those individuals are basically addressing the person. They're not addressing the concern. And the patients are reacting to who's coming in, and they're not reacting to what really is happening. So I think, just in summary, education is very important. I am also going to say, include the family members, even if they can't be there physically. And I have tons of literature which we talk about family members are extremely important. I think facilities like that should actually have it where they have scheduled time for patients to see their loved ones, not when needed, or PRN, we call it in healthcare. But just like they have breakfast, lunch, and dinner snack, they should have a time where they rotate and they're able to provide visual stimulation, if you call it, where they can physically see their loved ones on a rotating basis, and their loved ones can be able to communicate what's needed during that time. So I hope I shared enough, but it's so many variables in that aspect that you can address.
I think that's very important that you talked about the actual seeing their family members. We had my mother's 100th birthday on Zoom because she's in independent living. I could drive there in 10 minutes, but I haven't been able to get in the building since March. When you're working with people in a closed setting like a group home, you really need to find ways to engage them, and it's going to be individual. I have worked with individuals with intellectual disabilities years ago. They had different title then, but I did work with individuals who needed to have their own access to the community. And I can imagine they would be devastated if they could not go to their vocational setting or to their day program or to their school setting, whatever setting that they were used to going to. So there is a need to identify ways to engage them individually, ways to engage them as a group. If the staff happens to be a musician, they may not be a music therapist, but I bet they could do a music group anyway. But they need to do things with the people who are living in the group home so that they're not so bored that they have nothing better to do than try to run around the neighborhood or to try to break something. They need to get their energy out just like the rest of us do. We can't just be pent up like that and allow that pent up feeling to cause us to do things that are disruptive. Coming from the other side of that, when you talk about the interaction between the police and the community member, one of the problems we have right now, it shows on the news and it always seems like it's a black-white problem, but really it's a training problem. Our police in uniform are trained as if they're going into combat setting. So if they're trained for a combat setting, they don't really come in to de-escalate. They just come in to establish force and control. So we need to look at ways to change that training so that the police become an integral part of the community instead of a force up over the community.
And this is Dr. Allen. I think one question that I'm hearing, we're focusing primarily on the person with disability and also looking at the cultural aspect. But one thing that I have heard and I've seen, and maybe Dr. Allison, you as well, are our caregivers. We've realized, and I say formal and informal caregivers. We know in the hospital setting, and obviously a lot of people don't realize what's going on in the hospital setting. Our nurses are our heroes. Our other providers are our heroes. And they are, trust me, because they're focusing on the physical ailments or disability of people. They're looking at the cognitive disability. They're supposed to be the liaison, or whoever the healthcare provider is supposed to be the liaison or the advocate for the patient, but they can't really advocate for someone that they are just learning, or they can't communicate with the loved one in person, so they're trying to get a feel of what's going on. We're also finding out that the informal caregivers, which are our family members, our community, and our friends, they're also having some stressful times. And what we're realizing is if you pull up articles on COVID, what you're going to see a ton of is not the disease itself, because even Dr. Fossey mentioned today, we're still working on a treatment, we're still working on the vaccine. But what you're going to find is increased burnout, increased stress, anxiety, depression. All of these things are increasing, not only because of the disability and the COVID, but also due to the cultural aspects as well. And I think Dr. Allison stated it earlier when she talked about the income of these various households and how COVID has impacted them. So I think what we need to focus on when we're looking at the situation is, yes, we do look at the particular patient. We look at the situation as it becomes obviously right in our face, where this person with disability that has some type of cultural issues, and also there's some basically some COVID that's in there, or the prevention of. We also have to look at who's helping them, who's responding to their needs, and we need to address their needs as well. And that brings me to another statement I'm going to say. the needs of the caregiver can also be impacted by the way they're caring for their loved one. Because what they may feel, and I say this for people of color working in this capacity, is that they do not have support. Keep in mind, when we look at people of color, especially the African American Hispanic population, and also the Asian, I can throw this in, we see that who are the primary support group? Who are the caregivers when it comes to trying to care for someone with disability? Their family. The primary support group is not those in the hospital setting. It's not Alzheimer's Association. It's not Autism Association. It is their family. And when their family is not considered, as one of my colleagues pointed out, we call it social distancing, where we also call it unit-based distancing or separate distancing, where we have a unit of people in the same household caring for the loved one. When that family is not living in that household, then you begin to question, should I go over to relieve my family member who is caring for my loved one? Or according to the data, if I do, then am I going to contract or give them some type of problems when it comes to COVID? So we have to find out what virtual ways in which we can not only support the individual who is affected by it, but also the caregiver, because that's going to be our key.
Thank you very much. We have a comment from Liz. Liz, I'm going to unmute you now.
Okay. So you guys were talking, I believe it was Dr. Allison, about getting officers trained in working with different populations. And Erica also made a comment in the chat about getting officers trained with disability specific information. I'm actually a trainer for the East and West Valley, so Phoenix Metro. And I train on how to interact successfully with individuals with intellectual and developmental disabilities. So police departments are required to have a certain percentage of their officers trained in CIT. So they're going in the right direction. I've been training for probably 7 years, and there's at least 20 to 30 people in each class, 20 to 30 officers. It also includes dispatch. I've had FBI, Homeland Security, US Marshals. So the information is getting out there. It's whether or how they choose to use it. So I just wanted to make sure that people knew this wasn't something that officers are just plain not getting. They are getting, but it's not in academy.
Liz, I thank you for that information. And I know many of you all have seen this data. So in the United States, a police officer is trained 21 weeks. And as you all know, within so many months, we had over 1,000 deaths. Most of those deaths are due to cultural incompetence or mental illness. In other countries, police officers are trained over 2 to 3 years, about the length of a time of a nurse, if you will. And what I share with even with my staff and colleagues that I talk with, I said, if you had a registered nurse with a bachelor prepared degree that went to school for 21 weeks, would you feel comfortable with them caring for you? And they said no. So when we look at training, if you look at the most recent concerns that we've just encountered in the media, there have been 2 different groups that actually have been involved in those issues. A seasoned police officer, one who's been there for years and have been doing the same thing over and over and over again, and a new. It's always been a seasoned and a new. So the rationale behind training in my aspect is not just the training that we are offering them one time, because we do it here at Banner Alzheimer's. We do training. It's called Dementia Friendly Tempe, Dementia Friendly Phoenix. We've trained firefighters. We've trained police officers. But it's involving the training while they are still new and letting them know this is not a recommendation or not a requirement after you become, but you cannot become until you go through the extensive training of understanding who you're working with, whether it's the cultural aspect or whether it's the disability aspect. So I think that's important. I applaud you. I appreciate you, Liz, for doing that, but we got to look at who we are also talking about when we talk about these issues that we've just encountered.
Okay, I'm going to go to Jamie. Jamie, you have a comment?
I do. Actually, I just want to reiterate, I see Erica typed it already in the chat, and that's, I will acknowledge, as a professional working with the Division of Developmental Disabilities, I can also say that we have crisis intervention team training being done with officers, but I agree with Erica, it's not enough. There's definitely a need for disability specific training for all officers to happen just as a part of, starting their profession. For about the last year, and I'm still wrapping my head around it, I mean, the police departments, many of them throughout the state, I mean, they want. They're trying to be more educated. I go every quarter to Yavapai County Sheriffs, and I do a 101 level, a very basic level training, talking a little bit about each of the disabilities that my division works with, and then talking about what my division does for our community members who are eligible to join our programs. But I just recently saw that SARC, they put out an article that they're doing like virtual simulation training now with officers, where it's supposed to be really realistic. Anyways, I reached out to SARC, and I've reached out to a couple other people, and I know that the training opportunities for the law enforcement who are interested in it and who are interested in becoming part of the CIT, is getting better. The simulations are becoming more and more realistic. And I'm hoping that as I get introduced to that here in the next, hopefully, couple of weeks, I see more, I see more realistic interactions and more realistic scenarios put in front of people. So that's all I wanted to say. Thank you.
Thanks, Jamie. So there's some comments in the chat about CIT. Shellyan, excuse me if I'm mispronouncing that, shared that she went to a training in San Antonio, or they went to a training in San Antonio, and they learned a lot through that training. There is a question about the percentage of trained persons, if that's a state-by-state determination. And then I want to go to someone else who wants to share a question or comment. It's going to take me a minute here. Tempest, I'm going to unmute you right now.
Oh, thank you. Hi, so I'm a case manager at a behavioral health center specifically for people who have both a developmental disability and designated serious mental illness. So I, hear a lot of interactions with police and people who have developmental disabilities because of that added, level of mental health. And what I've found, and what a lot of people have been commenting on with the training, is that it's a great start. But until all officers are trained, it's always going to be a little, possibly dangerous for our clients or our patients or our family members to interact with police, because we can't guarantee that the police they're interacting with are trained. And because I work in mental health, I also have a lot of exposure to other organizations that can help when appropriate, like Teros or other crisis response teams. So I feel like it's great to train our police, and that's going to be absolutely necessary and important for their future. But right here and now, it's also great to consider, is it time right now for police intervention, or can we utilize a crisis response team? And will that be less scary and less dangerous sometimes for our people with developmental disabilities who have mental health issues, and maybe even for cultural reasons are scared of the police? And yeah, that's all I wanted to add.
That's a good point. And I just want to throw this in. I don't know if you all remember, 2 years ago, Chief Jerry Williams, we had an issue with culture, police officers, and I believe it was a person who had some mental illness, African-American male and mental illness. It was on the news. And the police officer did not know what to do. And so obviously there's some interaction, and of course it got exposure. One of the things that Chief Jerry Williams mentioned was that we are not trained to do those things. So what our goal is to not only involve our community, but to involve those who are specialists such as yourself. And how do we do that? Well, when we get a call like this, I don't know what happened to this, and perhaps it's still being implemented. When we get a call like that, we will have the police officer and also the, you know, whoever the trained person is, mental health professional, be involved. They could either talk the police officer through what's going on in an earpiece, or actually being there because they've been trained to do so. So one of the things that we're hoping is that continues. But as I pointed out earlier, I think what's happening is, I'm sure you all know, they talked about defunding, and as you all know, in relationship to defunding, it's not removing money from police, it's putting money in different areas of policing. And one area that they've identified was putting money more into training police officers to do. But I think it was once stated, could have been Minneapolis, who stated, the chief at that time said, not only are we interested in training police officers to do, but we're interested in getting new police officers and training them at the beginning so that they can be part of the culture. And I think that, again, speaks volumes. When he said that, I said, yeah, that would work more so than training the existing, because you have police officers who have been doing things a certain way because that's just what they know, and it has worked for them and they have gotten away with it. And do you think they're going to change? Not really. But when we get a new group, we get this new cadets, if you will, I think they start off in that, and begin to let them know this is part of our culture. This is how you're going to do certain things, and providing more than just 21 weeks of training. And by the way, I think someone asked that question, that's in the United States. 21, I think it's 21 to 30 something weeks of training compared to other countries who have had 2 to 3 years and have had probably in a year, maybe 5 or 6 deaths, because they've been trained how to handle people with disabilities and also how to handle people of color.
All right. We have a hand raised from Christopher. Christopher, I'm going to unmute you. Since you're on your phone, you're going to have to make sure your phone is also unmuted if it's unmuted.
*6 on your phone, Christopher, if you want to try that. I'm going to try one more time for unmute, Nick.
Are you able to hear me now?
There we go.
Perfect. Well, thank you guys all. I want to say thank you for everyone that's here today. This is my first time attending, so I really am looking forward to further discussion. I like the discussion around, and Dr. Allen had just kind of briefly touched about like the defunding police, and we're talking a lot about police here. I'm just curious more so if the reallocation of funding and talking about, I think the issue is behavioral health and a lot of the individuals that are providers not having the training so that the police don't necessarily need to be involved as much. Is there something occurring? I know this is more so at the legislative level and getting some funding, but is there any movement to get some funding put in so that those trainings could happen?
Chris, are you saying the trainings could happen with the police officers, law enforcement, or another?
No, this is more so for providers and behavioral health staff, so that way that, because a lot of times the individuals that are in these homes taking care of individuals with disabilities don't necessarily, I feel, have the training, proper training to, you know, de-escalate behaviors as they occur. And oftentimes is the reason why, you know, police are sometimes contacted as often as they are. And I think that a lot of times, a lot of good staff, unfortunately, most of the staff are paid minimum wage. And, you know, especially.
Yeah, so let me just answer your question. And again, this is me being a very good friend of a police officer. As a matter of fact, he's going to be doing a presentation next week. And I'm somewhat knowledgeable in certain areas, but this area, I can tell you that defunding comes state by state. So what they do is they prioritize what the state requires. Just like COVID, when we're doing our you know, interventions and whatever we need to do and following certain guidelines is state by state. It's the same thing with defunding. It's state by state. What happens is, like in Atlanta, they're defunding. They just started their defunding process primarily because of what just recently happened a couple of weeks ago with the young man in Wendy's. And so each of the states are identifying what is their main need. So in our state, I don't think that our major need is primarily with culture. We wouldn't focus primarily on culture, particularly with the African American, because our number is so low, 5%. Our monies may be going to cognitive impairment or some other type of disability because of that's what we're looking at. Whereas in Atlanta or Minnesota, they are looking at cultural issues because of the large percentage of their diverse population, particularly the African American. So it's primarily state by state. If you're speaking to legislative, that could be a voice heard and shared and stated that, yeah, here in Arizona, we should be looking at, if we're reallocating our funds, they should be focusing primarily on healthcare professionals.
I think also we really do need to push for better pay for those professionals that are working in those group homes, in the community, because the minimum wage is not sufficient to support a person with the right training to do what they need to do. Often you're pulling people, they finished high school, maybe took a year of college, maybe two, but not anything specific to the field they're in. They needed work, and this was something they could get work in. I really think that we've got to, across this country, find better ways to value the services to humans and pay people who are caregivers professionally so that they are paid at a rate that allows them to do their jobs well.
So the highest turnover in any hospital setting, and I believe Tempest could say, agree with me on this, is the highest turnover is behavioral health department. Because you have a large number of people who are there, and the nurses or even the physicians, they may be there for a certain period of time, but because they're not seeing a true outcome. Think about it. When you have a person admitted on a behavioral health unit, that person's admitted, and they are admitted because they are in a state where we or the community or a regular unit cannot handle them. So we're then offering, as Dr. Allison said it early just now, we're offering them to a unit which we assume they know exactly what they need to do. I'll give you a quick example. One in particular is dementia unit. We're placing our patients on behavioral health units in large healthcare facilities. And we're saying to these people, we can't handle them in the emergency room. We can't handle them on an acute care unit because they're not going to take the medicine, or they're not going to let the IV stay in their arm. So we're going to place them on a behavioral health or even a skilled care unit where we have behavioral health team members that are going to address the concern. The priority is not going to be their illness. The priority is going to be the behavioral issue that they are encountering on that unit. Now take the staff. The staff that they have are people who are actually from other units. Because of the high turnover, they are actually being pulled to those units, and they are not even being trained, but told, this is what you need to do for this person because I know him from yesterday. So I totally agree with the person who spoke earlier. Yes, we do need to start putting our funds in training people more and being able to not just put out fires, but helping these individuals so that they can address the concerns and they can be placed back into whatever community they came in. And then the last thing is, not only do we actually want to address those concerns, and I think this was said earlier as well, we also want to look at how do we educate the family member, because that family member should never be considered a visitor when they're coming on those units. That family member should be considered part of the team where that physician, whether that doctor, the nurses, the social worker, the case manager, Tempest, can say, hey, this is what has helped us. This is what causes your loved one to do certain things. This is what triggering their behavior, and not have a medicinal approach, because we know pharmacologically that's actually money there, but having a non-pharmacological approach on this is what you would do if this happens, so that we can try to keep this individual in the community setting. So I love the fact that funding should go to those who are working in the healthcare setting, because again, the highest turnover is in behavioral health.
We have a hand raised from John Myers. John Myers, I think you're unmuted. Do you want to check if your phone's muted?
Yeah, I think I'm good. I wanted to circle back to something that Dr. Allen touched on just a few minutes ago, and I don't want to beat this into the ground, but I've noticed a couple of comments in the chat as well, and that has to do with training As a product of the Hacienda healthcare incident that took place about 1.5 years ago, the DD Planning Council formed a safety collaborative, or an abuse and neglect response collaborative, that's actually a statewide body and includes providers, it includes folks from law enforcement, and includes folks from state agencies, including Adult Protective Services and DDD. And basically the thrust of this group is to focus on issues, again, primarily abuse and neglect issues. Sexual abuse of individuals with IDD was the genesis of this, but also to look at the variety of things that affect individuals with IDD and their interactions with the service system, including law enforcement. I happen to chair a criminal justice and vulnerable adults subgroup as part of that collaborative. And one of the things that we have discovered, talking again about training of law enforcement, is that in addition to whatever issues we have with culture or ethnicity or skin color, in the vast majority of cases, law enforcement officers or first responders are not familiar with disability issues. So there may be issues of race that are present most obviously, and then they're just compounded if issues of disability get added to the mix. So we absolutely need to be doing more to train officers, and we're working with AG Post, which is the Peace Officer Standards and Trainings division. It's responsible for certifying all law enforcement officers across the state, and they are now participating in the work that we're doing to ensure that the resources developed and the resources made available to first responders and to peace officers moving forward are more culturally sensitive, are more culturally aware, and do include the unique attributes of the populations that we serve. There is a tremendous amount to do, and certainly it makes sense that we want to capture cadets when they're first coming in, and we want to make sure that they are getting the best possible awareness training they can get, so that as they head out into the field, they are treating the folks they serve and protect as servants and protectors, and not as adversaries or not as unknown quantities. So it's work that we're doing. As I said, it's a statewide collaborative. We are absolutely trying to put together resources that can help individuals with disabilities from all communities across the state, but also help those who are charged with protecting and serving those individuals, and have them do it in an aware, an educated, and a just manner. So I'll leave it at that. If there are any questions, I'd be happy to address them.
I'd like to piggyback on what John said. We do something so well. The Arizona Center for Disability Law every year has an African American conference for the last 9 years, and Dr. Allen has been a speaker at our conference. And this past session, and we usually have it in February. This past February, we had a session that was with the Phoenix Police Department. And they came and spoke concerning what they're doing, and the programs that the Phoenix Police Department has put into place right now, which included crisis intervention, bias crimes, and the police chief has a cross-disability advisory board. And I sat in on the session, and it was a well-attended session, but it was also a very guarded session from those who were attending as participants. So this is the second year the Phoenix Police Department has participated. But afterwards, we did hear some really great views from both sides, and we think I think making those connections with police departments like that and having them come speak to your community has really gone a long way. They really enjoyed our conference. They want to come back. I think so. Just engaging in those really healthy discussions, whether or not, there might be some, there was a little bit of contention within that session, but you have to have those in order for all of us to move forward. And I will bring this up down here in Tucson. This just came out on my news feed, and I just got a message about it. So the Tucson Police Department released a video of a young man, Hispanic man with serious mental illness that died in Tucson police custody. And that happened in April, and we're just finding out about it today. So already people have resigned this afternoon. They're thinking the police chief might resign. The mayor and council canceled their meetings. So there's a lot, you know, it's obviously, this is going to be an ongoing thing, and I'm sure it's going to make national news. But, you know, so I'm hoping that out of this situation, maybe we're having discussions with other police departments like Tucson Police or Flagstaff or Yuma, and having these type of community forums where there need to know more understanding and more training.
I just want to throw this in. So when this issue with George Floyd obviously was brought to our attention, particularly at Banner Health, I've done it with ASU and Banner Health. You know, I sent out a long letter because I'm coming from an African-American perspective, and I wanted to let people know, you know, how I felt, but yeah, it was something that I also ended in, and it was not only how I felt, but what are some of the things that I would recommend Banner Health to do? And one of the things, and I appreciate John when he says that, I said two things, and that was, we need to have a seat at the table, because we as healthcare providers in a large organization, our D&I team needs to actually say, hey, we're at the table. Let me tell you who we have under our umbrella so that we can address the concerns that you have. So that was one thing. The second thing I wanted to add, and this was something that we analyzed, a couple of colleagues and myself analyzed, and again, the young lady who works in behavioral health may have addressed this as well. If you look at some of those videos, particularly the last one, and I don't want to give a name, the last one about the social injustice and the police officer involvement and whatever, and I truly appreciate John stating what he says, and also Natalie, you sharing what you said. Look at how the police officer communicated to that individual prior to his death. The way he talked to him, not realizing that at the end of the day, I don't know if you all knew, and this was, just throw it out there, one of the cases that occurred national news, that person had a background of mental disability, mental illness. He had some disability. And later when his family shared that, I then went back and looked at the video again, and I said, no wonder why he really couldn't understand. And his whole response was, and I think we brought this word up, and if not, we need to. There was PTSD on the police officer's stance and PTSD on that person's stance. But when you have those two situations, along with the fact that you just tangled my words and now I'm truly confused and you can't handle me the same way you would handle a person who knows what you're talking about, my response is going to be what I did. And then I just did what I did and you did what you did. So I think we have to really take, and I'm very appreciative of Phoenix, and I know Jerry Williams, Chief Williams personally. I'm appreciative of how she's addressing some of the concerns now, because we do have a large number of mental concerns in this state, being that, you know, obviously we have very diverse cultures, we have large hospital settings, and again, we're number 2, believe it or not, when it comes to dementia. So in the country. So it's really interesting that we do have to look at those things.
When we have the opportunity to participate on community boards that are guiding the process, I would encourage any one of us to guide it to, can we get training that is local to a neighborhood? Because I know that if the police close to our church are familiar with the fact that there are a number of group homes down that block, and they come in a different way than police come into this neighborhood by my house. You know, I think that they have to have not only the training for disability, but maybe more training when they know that's their precinct, and maybe training for a different group of people when they know that's a different precinct they're working in. I really think it needs to be brought down to the local level.
Okay, I see a hand raised from the phone. So I'm going to go to the phone 3477, phone number. I'm going to ask to unmute you. Again, you're going to make sure your phone is unmuted if it's also on mute.
Can you hear me?
Yep.
Oh, okay, I'm loving this robust conversation of different ends. I think personally training is a wonderful thing. I think communication is a wonderful thing. However, I think there's a key component that's missing in the training piece, be it of addressing those with intellectual disabilities, interactions with authorities, access to care, the whole shebang. The piece, similar that if for what I've done in work, if I issue out a survey on month 1, people take the survey, get some results from that. Then let's say go the whole year and then, do the same training again in January. If I don't follow up on the workshop that was done in January, how am I assured that the training was effective and also being applied appropriately? I think, yes, the changes of behavioral health, dollars for training both for community members, those in positions of protecting community members, is a valuable thing. But then there also needs to be that follow-up piece that says, okay, yes, if you've done training on day 1, and then you've had 30, 60 days or what have you of implementation or potential ability of interacting with different folks from community. Now let's come back that 60th day, resurvey. What have you learned? What have been the challenges? What do we need to tweak and change so that it's continual development, not just one stop and done? I think on both sides of the equation, that those with and without, that's similar to how there was the discussion of the conference which was had. Yes, there's angst on everybody, not just those with badge, with authority. That's just the charged feel of many communities right now. I echo the sentiment that when those trainings and different things do take place, that go in with that ground rule, similar to how the beginning of this call, it was very well broken down, the different perspectives and things of that nature, so that there's a solid foundation that helps build the trust for a true communicative process. Thank you.
Thank you very much.
And I appreciate that, speaker. In the research world, we used to say outcome because we wanted to know in numbers, how is that going to obviously affect whatever you've done? We dose them, we have an outcome. Now I'm hearing more input, or endpoint, excuse me. Endpoint is we have a baseline, and how do we measure where we started to where we want to be? And that to me is the more impactful way. So I truly appreciate that, speaker. It's called follow through. And not only is it follow through, and again, many of us know this, when something happens in the police world, if you will, law enforcement, oftentimes whatever occurred and whoever was involved, they have that session with the sergeant or the chief, and they're talking about what went wrong, what could we have done better. Well, now we need to look at it as a learning perspective. You are wearing the cameras, whether it's the person on the other end, which most of the time it is their fault, or if it's the police officer's fault. Let's replay that camera. Let's have all of the police officers, depending on what shift you're in, and let's role play and say, how could we have done this better? What went right and what went wrong? And when we begin to start incorporating that along with the training process, we are now applying what we've learned in training to our skills, what we've actually done in the unfortunate situation or fortunate situation. So I really appreciate it. It's basically it's follow through. It's not a one and done. It's not a module, you get 80%, you pass, move on. It's knowing what you need to do in any given time. And I think, just as I kind of wrap up, I just wanted to say, what needs to also take place, and I think is more important, I love this panel, but to have, I thought of the healthcare professional that was on, the behavioral health person that was on earlier, to have that behavioral health, that police officer, that healthcare professional, that family member or community person who's working with a family who has a disability, all on one panel to say, how do we address certain situations that we're encountering? You may have done that, but I think that's just so important.
I agree. Definitely the suggestion that you make sure that you're checking up after 60 days to find out what didn't work. It's important to know also, if I trained you to do this and it didn't work, then maybe we should be doing something differently. But how will anyone know if we aren't doing that follow-up to keep track of the progress and the effectiveness of the training we're providing.
As we kind of enter our final minutes here, I want to catch up and read aloud some comments from the chat. BB shares, I appreciate this discussion and would like to see a continuation on this topic. It should be explored on how our service providers could be a partner in trainings, especially for the SMI population. Christopher notes, CIT should include more emphasis on understanding confusing behaviors rather than just how to keep yourself safe when aggressive behaviors are happening. Liz, who spoke a little bit about some of the trainings that she's put on, shares a little more details. Staff receive training in prevention and support for DDD, which includes verbal techniques and relationship tools to be used prior to physical restraints. Staff are supposed to use these skills prior to calling 911 for behavioral concerns. Behavioral concerns is hands off, so 911 is typically initial call if verbal de-escalation is not successful. Vicky shares, there's a book called The Age of Dignity by Jen Poo. She is focusing on caregivers and caring for elder care and having this vocation be valued. Rachel shares, these factors contribute to higher levels of stress among the providers. Just like in childcare, they are responsible for people's relatives, and that's not an area you want to go low budget on. Service providers need to be valued if we can expect quality, caring service provision. Let's see, okay, Liz shares, it's up to the agency to inform the police department when they have group homes or programs. If the police have this information, perhaps dispatch will be able to provide the information to first responders so that they can respond more appropriately. Let's see, on some of the more recent comments that follow up, Maria shares that in her field, they call this fidelity of implementation. Let's see. Vicky asked, does training for police provide exposure to people with intellectual disabilities in person? Let them talk to family members, speak to them as a family individual perspective? Tempest, I agree and feel there needs to be accountability on the side of trained PD. It needs to be shown that training decreases it needs to be shown that training will decrease actual traumatic encounters or not. So some data on that. We need qualified individuals to hold positions and be paid accordingly, not just a warm body. This session is interesting, thank you. Okay, I think we're caught up mostly with the chat. I don't see any other hand raise.
Okay.
Jamie shares, Vicky, there is a program called Be Safe, where people with IDD diagnosis can learn how to properly interact with first responders. This allows for some, quote, in parentheses, very little police to have contact with people with diagnoses.
All right, well, we just have a few minutes left, so if you want to grab, ask a couple more questions, and then we'll wrap it up for the day. And I think this has been a very fruitful discussion, and hopefully we can have more discussions like these. And I'd love to have Dr. Allison and Dr. Allen come back, and we can try to figure out what our next session will be. So are there any further questions? How we build access to the recording to today's panel? They're usually up within the next day after. Am I correct in saying that, Nicholas?
I think the next couple days after, it'll get posted to YouTube, and Sarah says make sure that we'll email out to everyone as well when it gets put up.
All right.
Dr. Allen, I thank you again. This has been a wonderful opportunity to share. As you all know, in this process, it's been so many moving parts. As I've mentioned, the term variable, and I don't use that loosely, because each of the areas that we addressed are extremely important at this time. We look at disability, not just intellectual, but also physical disability. We're also looking at cultural aspects, not only just people of African-American color, but also people of color as a whole. And then we also know that the COVID-19, the physical or physical issue, if you will, is out there and affecting us as a whole. So I think it's so important that we make sure that we address each of these areas as an individually, and then also looking at them as a whole so that we can not only meet the needs of this person who has any type of disability, but we also meet the needs of those who don't understand. And I think that's the purpose of this. Our goal is to advocate for those who are disabled, but also to inform those who don't understand who we work with.
I also am really happy that I was able to participate in this discussion. It's just very important that we consider all of the social impacts, because there is no one area you can look at that will resolve the situation we're in. You can't just look at race. You can't just look at disability. You can't just look at health issues. You have to look at it all, because every person is an integrated individual with a lot of different factors impacting them.
So I think to close, we're going to go to Erica.
Hi, thanks, Nick. So I saw in the chat box that that people were really interested in this discussion and wanting to know how they can get involved and what can we do to address some of these topics mentioned today. And I just wanted to mention that our group here, we're also involved in this community of practice. We have a grant through Georgetown University. It's a 5-year grant, and the whole point is to address cultural and linguistic competency and ensure that our systems are inclusive. And so if you are all interested in being part of that effort, I guess you can email me, Erica McFadden, or Sarah Roof, or whoever's email you have, because all of us are part of that, all of the network is part of that collaborative. So that's one way. There's also a group called the Arizona Safety Coalition. I'm not sure if Nancy Martinez is here today, but that group is actually working with the police and with disability advocates to better determine how to keep our people safe, whether it be through training or teaching people with disabilities to be safe. But that group is actively trying to find ways to ensure that that those practices are improved. So that's another way. And I'm sure there's other groups out there. I mean, does anybody else in our network have any other ways for people to get involved?
I think what you mentioned, Erica, is great. We do have roundtables. And so I'm also a part of the Cultural and Linguistic Competency group. So if you want to, I put my email in the chat. If you want to send me an email, I'd be happy to add you to our emailing list. I think right now everything's going to be obviously virtual, but I just say, contact your, local departments, your local police departments or sheriff departments or any sort of agency you feel is, they need to hear from the public. And that's what we should be doing. All of us should be doing. Jamie just says Phoenix Police Chief Advisory Boards are often looking for more to join. So I'm sure if you go to their website, you could find it, but we can also add that to our FAQ page. So, okay, well, we normally have calls hopefully once a week or every other week. So you'll be hearing from us again, and hopefully we can have a continuation of this discussion. I don't see that this issue is obviously something that's constantly evolving. So without any further questions, really appreciate your time today. Again, Dr. Allison and Dr. Allen, thank you so much. And if there are no more questions, have a good rest of your Tuesday afternoon. Thank you.